Hello, thank you very much for this invitation. It's really a pleasure for me to be here. In the next 15 minutes, we will discuss the clinical respiratory management of COVID-19 in low and middle income countries. I have no disclosure related to this lecture. And this is my agenda. I would like to briefly start with a discussion about COVID-19 versus non-COVID-19 ARDS, and I will try to show you data that support that we should use ventilation strategies already validated in ARDS, also in patients with COVID-19. And then we will discuss these domains of the clinical management of patients with COVID-19. So first, COVID-19 ARDS, is it different from ARDS of other causes? From a clinical perspective, no. So just talking about ventilation, COVID-19 ARDS should be managed as we manage other causes of ARDS. So this is a nice summary of several studies showing that virus was already a prevalent cause of respiratory failure in our critically ill patients, but we don't have any formal studies showing the incidence of viral pneumonia as a risk factor for ARDS. However, it is expected that all randomized clinical trials in the ARDS field included a substantial number of patients with viral pneumonia too. So this is really important. Also, the compliance was a huge debate in the beginning of the pandemic. Some studies suggesting that COVID-19 ARDS presented with higher compliance, but we have data from several studies from Argentina, Netherlands, Spain, France, Belgium, Italy, and USA showing that the compliance is around 30 to 35, what is similar to patients with non-COVID-19 ARDS. So altogether, this suggests that COVID-19 patients should be treated as non-COVID-19 patients regarding the ventilation, the mechanical ventilation. I would like to emphasize again that I'm not talking about drugs. I'm not talking about physiology or physiopathology. I'm just talking about mechanical ventilation. And the evidence that we have to ventilate patients without COVID-19 should be applied to COVID-19 patients too. So my talk will be based on this guideline. We prepared this guideline some months ago. So this is basically some recommendations for the management of COVID-19 from a ventilation and respiratory perspective in low and middle income countries. The full text is available in the American Journal of Tropical Medicine and Hygiene. So let's start with the oxygen therapy. So we suggest starting supplementary oxygen when SpO2 is persistently lower than 94. This is a weak recommendation with a low quality of evidence. And the rationale is basically that you should keep close attention and monitoring when using a low SpO2 target. So, and it's really important in this case because we know that frequent ABGs or even continuous SpO2 measurement is not always available in low and middle income countries. So if you decide to start and to keep a low SpO2 target, it's good to have a good monitoring and to keep a close monitoring of these patients. This is in line with other guidelines too. We recommend supplemental oxygen to keep SpO2 around 88 to 95%. So we recommend a conservative target of oxygen. And this is based on the idea that hyperoxia is frequently associated with harm. We have a lot of evidence suggesting it. But it's always important to understand that a lower SpO2 target in patients without conditions and in select settings, so in settings where you can keep a close monitoring of the patients, may avoid harm, and most importantly, it spares oxygen. So in some cases, we know that some settings are suffering with the lack of oxygen. So if you use less oxygen and if you aim a lower target of SpO2, you can spare some oxygen and save some oxygen. We have several studies supporting the idea of conservative oxygen therapy. I'm just showing you one. This is the IOTA meta-analysis suggesting that a conservative oxygen therapy is safe and maybe even associated with benefit in patients receiving treated with oxygen in the ICU. We also suggest a higher SpO2 target in settings where you don't have a continuous SpO2 measurement. So if you are not able to measure SpO2 continuously, maybe it's better to target a higher oxygen target just because you increase the safety of the patient. So we suggest 88 to 95% for everyone. But if you are not able to have a continuous pulse oximetry, it's better to keep 95 to 97% and increase the safety of your patient. We also recommend using low flow oxygen systems for supplementary oxygen. And whenever available and wherever available, a no rebreathing mask is the best option. And why? The rationale behind it is because it helps limiting the dispersion of droplets. And it's really important that you can achieve a higher FiO2 at lower flow rate. So you can, again, spare some oxygen, you can save some oxygen and provide higher FiO2 if needed. So this is what we suggest in our guideline, and this is not mentioned in other guidelines. Regarding the use of non-invasive ventilation strategies, we have some recommendations. So the first one is now, after months learning with the pandemic, we suggest using the high flow nasal cannula or the non-invasive ventilation with close monitoring and isolation. And in patients who remain hypoxemic despite the low flow oxygen therapy. So if you started with the low flow oxygen therapy, the patient is still hypoxemic, you should try high flow nasal cannula or non-invasive ventilation if available. It's really important because it can reduce the need of intubation, but it requires close monitoring because you should identify the failure and intubate the patient really quick. It requires the correct interface and isolation to avoid dispersion and to keep the patient comfortable. But you should always be attention with the high oxygen consumption, especially with the use of the high flow nasal cannula. So if oxygen is a problem, maybe the high flow nasal cannula is not the best option. The NIV could be a better option. This is a study from Brazil, so a low and middle income country, showing that the use of non-invasive respiratory strategies like the non-invasive ventilation or the high flow is associated with better outcomes compared with the use of mechanical ventilation alone. We suggest a trial of awake prone positioning in patients who remain hypoxemic despite the use of oxygen, high flow, or non-invasive ventilation, and who do not exhibit signs of respiratory distress. So awake prone is increasing, and we really think that is something that you should try, especially because you can improve the oxygenation and spare oxygen. You could prevent intubation, and it's always important to keep the patient prone as long as possible for at least 3 hours per session. And this is a really nice data from the MEDA trial showing that the awake prone positioning is associated with increase in SF ratio, decrease in respiratory ratio, increase in comfort, and reduce in the treatment failure and reduce in the need of intubation. So it's a really effective and important strategy at no cost almost. Regarding the intubation and the mechanical ventilation practice, and this is the most important part maybe of the presentation, regarding intubation, we recommend intubating and initiating invasive ventilation based on signs of fatigue and respiratory distress rather than hypoxemia alone. So this, in the beginning of the pandemic, we were intubating the patients just based on hypoxemia, and we learned that now we should focus more on signs of fatigue or respiratory distress. So this is really important. However, we should always weigh the risks of premature against the risk of delay in intubation. We should avoid this delay in intubation at any cost. But hypoxemia alone is not necessarily an indication for intubation. So if you only have hypoxemia, you can try to solve with the non-invasive ventilation strategies. But if you have respiratory signs of distress or fatigue, so you should proceed with the prompt intubation of the patient. We recommend a close monitoring for respiratory distress and worsening, especially when you decide to avoid intubation. So you decide to, okay, I will not intubate this patient now. I will try to use a non-invasive ventilation strategy. So in this case, it's really important to keep a close monitoring to intubate the patient if needed as quick as possible. So again, the key here is to avoid the delay in the intubation. Always consider the respiratory rate as a guide. So if you have a high respiratory rate, consider intubation, and also use other indices whenever possible, like the ROX index for patients receiving high flow nasal ventilation. And always consider a more liberal approach with the use of non-invasive and high flow, as long as the patient doesn't present signs of discomfort or clinical deterioration or respiratory distress. So this is really important. You should not delay the intubation using non-invasive ventilation. This should be avoided at any cost. We always recommend using a low tidal volume ventilation with a tidal volume of 4 to 8 ml per kilograms of predicted body weight. And whenever possible, a tidal volume below 6 should be pursued. This is based on the best evidence that we have for non-COVID-19 ARDS, and this should be applied to COVID-19 ARDS too. We know that from a ventilation perspective, COVID-19 is not so different from non-COVID-19 ARDS. and low tidal volume ventilation is widely recognized as a beneficial therapy in patients with ARDS for more than 20 years now. This is a nice study again from Brazil, a low and middle income country, showing that the use of protective ventilation with low tidal volume and low plateau pressure was associated with better outcomes compared with a non-protective ventilation strategy, supporting the recommendation of low tidal volumes in patients with COVID-19. We recommend a low PEEP and high FiO2 table from the ARDS network group. We recommend this because we think that for less resourced settings where you don't have a lot of monitoring tools, the low PEEP table is usually safer than the high PEEP table. So it's again the weight of the risks of higher PEEP levels and its consequence like barotrauma, hemodynamic instability, especially in settings where you are unable to provide the adequate monitoring. However, when possible and in experienced settings, you can always consider the high PEEP, low FiO2 table, especially because with this strategy, you can spare and save some oxygen too. We recommend against the use of routine recruitment maneuvers because of, especially from the ART trial data, it's from a low and middle income countries trial. It was associated with increase in harm. So we suggest using the recruitment maneuvers only as a rescue therapy in patients with refractory hypoxemia. Otherwise, you can induce more harm than benefit. We recommend using prone positioning for 12 to 16 hours in case of refractory hypoxemia, in this case defined as a PF ratio below 150 with an FiO2 greater than 60% and a PEEP greater than 10. This is a strong recommendation based on the PROSIVA trial. So again, this is from non-COVID-19 ARDS, but we should translate this to COVID-19 ARDS. So if you have a situation like this, you should use prone positioning for at least 12 to 16 hours. Regarding the weaning of mechanical ventilation and extubation, so weaning of ventilator, we recommend daily assessments for readiness for weaning by low-level pressure support trials, and we should encourage you to use local protocols used for weaning. So the protocols that you use for general weaning should be applied for COVID-19 patients too. We recommend against the TPS trials because of contamination risk, so we recommend using the PSV for the weaning of these patients. And the major reason here is that because the use of TPs is strongly associated with the generation of droplets and increasing in contamination too. And we recommend using familiar local extubation protocols to minimize the infection risk among the healthcare workers. So do the protocol that you are familiar with and that you already do in other patients receiving mechanical ventilations in your unit. But it's really important to have local protocols and to follow these protocols for the weaning of patients with COVID-19. Staff members should wear PPE during extubation. This is really important. Efforts should be made to minimize coughing in these patients. Always consider high flow nasal oxygen or cannula or non-invasive ventilation after extubation, because these patients, usually they are at increased risk for extubation failure. And consider a face mask for the patient after extubation if possible and if required. So in conclusion, from this lecture, again, I recommend you reading the guideline. It's really nice, it's really comprehensive, and we have all the evidence and all the papers there. So keep simple strategies, it's really important. Apply already available and evidence-based supported strategies. So remember that from a ventilation perspective, it is okay to treat COVID-19 patients as non-COVID-19 ARDS. We have a lot of evidence for these patients without COVID-19 that we should translate and we can translate to COVID-19 patients. Be restrictive with oxygen. It's really important. Consider strategies that reduce the need of oxygen, especially to save oxygen in your institution. We know that a lot of settings are suffering with the lack of oxygen. So if possible, use higher PEEP. If possible, avoid high flow nasal cannula and use non-invasive ventilation. Consider the no rebreathing masks to have higher FiO2 at lower flow rates. So always remember to be restricted with oxygen. It's really important. And finally, and least but it's really important to remember that one size doesn't fit for all. So check your institution in your local protocols and follow your local protocols based on evidence to give the best support for this group of patients. Thank you very much again for this invitation. It's really a pleasure, and bye-bye.